So hopefully, if any of you have diabetes or prediabetes, you have heart disease, the risk of getting diabetes is higher. But we're going to go over talking about diabetes and heart disease in combination. Do you want me to admit Zoom? Is that someone in? Yeah, it's okay. It's okay. It's not going to let me know. Okay. I got stuck again, Brad.
So just put the mouse, you move the mouse, it has to push on the screen and then it hits the button.
Oh, okay. All right, sorry about that. So let's start with diabetes, where we are with diabetes in the US. Last time I presented for the mental hearts, we were at 31 million people with diabetes, and now it's 37.3 million. Diagnosed 28.7 and undiagnosed 8.5 million. This is just in the US. With prediabetes, we have now 96 million people with prediabetes. So that is going up very fast. And 65 years or older is 26.4 million. So that's almost like 50% of people over 65 that have prediabetes. And unfortunately, many of those people don't know they have the risk for diabetes. If they don't get tested or they don't have doctor's appointments, there are no symptoms. The only way to know is getting lab work done and showing your glucose there. But every year, 1.4 million Americans are diagnosed with diabetes. And this is according to the American Diabetes Association. So it is going up extremely rapid. I always like to show people that there is a way that you can know if you have the risk for diabetes by doing a pre-diabetes risk screening. This is a 60-second screening test that the ADA, the American Diabetes Association, and the CDC finally came up an agreement that they were going to use the same risk assessment for prediabetes or diabetes. And so this one is 60 seconds, it's 7 questions. And all you have to do, you can print this from the website from the American Diabetes Association or the CDC and answer those questions. And the little boxes here, you put the number. If you get a point, if you get 0 points. I just did mine before I came in and I am a risk. So once you add the numbers there, and then the last one is about your weight. You find your height and you find the row where your body weight is. At the bottom, you'll have the points that you need to add into this little box. Then you add them all together. If you score 5 points or higher, it is a risk for diabetes. And I have 5 points. Diabetes runs on both sides of my family, so I don't have diabetes yet, but I know that I have very high risk to get it. So I need to be screening myself once in a while. But do it and ask your family and friends. Get your loved ones to do this to see how many you can find that have the risk for diabetes. It's such a difficult to manage disease. It's a lot of work, and we want to catch it at this point when we have the risk to do something, hopefully, and get everything back to normal. And hopefully delay, prevent getting type 2 diabetes. But not something needs to be changed when we know we have the risk. We need to do something about that. If not, we're going to get type 2 diabetes faster than we think. So we should be worrying about these numbers. A recent study published in the Journal of American College of Cardiology found that between 2025 and 2060, which is a couple years away, this is very scary when I saw this, the number of Americans with type 2 diabetes will increase to 40%, to 55 million. And many years ago, the CDC mentioned that they had the data out that by the year 2030, 1 out of 5 people in the US will have diabetes. And that by 2050, 1 out of 3. So that's a lot of people with diabetes. What worries me is that we don't have enough specialists that can manage diabetes We don't have enough diabetes educators. That's why we try to educate the community to get screened early, catch it early, get lifestyle changes going, and hopefully they can prevent getting type 2 diabetes or delay it, right? But these numbers will go up fast according to this study. High cholesterol rates expected to increase about 30% to 126 million, and high blood pressure increased to 25% to 162 million. So as a result, researchers predict that heart failure and heart disease in general will be going up by a third, right? So what do you think is the common denominator for this? Why do you think this is going up? What will you think? I'm going to give you the answer right now. Obesity, weight gain. Weight gain, being overweight or obese causes a higher risk for getting type 2 diabetes. It doesn't cause diabetes. There are a lot of obese people, overweight people, they never get diabetes, but it does increase the risk of getting it. So all those numbers that they're saying they're going to go up between 2025 and 2060 is due to obesity. So we're always worrying and asking people that they need to lose weight and they need to do something. And so we'll spend quite a bit of time talking about weight loss and what's available for people to help them lose weight. Also, the cost of diabetes. Having diabetes is extremely expensive. A lot of people are not able to afford their medications. It's very sad when they cannot afford their insulin and they need insulin. Is choosing between having food or taking their medications or start rationing their insulin because they cannot afford to get the next order. So this was in 2018. The estimated total cost them was $327 billion a year in the US just to manage diabetes, which went up from 245 billion in 2012 to 327 billion. And then you can see here that the largest component of this, the medical cost, is inpatient admissions. When people get admitted to the hospital, not necessarily because of diabetes, but or the diagnosis of diabetes, but a complication from diabetes. They could get admitted with a heart attack, stroke, a lot of that heart disease. So a lot of it goes through the hospital inpatient admissions, prescription medications, which I said are very expensive, and the anti-diabetes agents and diabetes supplies, test strips, devices that they're using now, the continuous glucose monitors, insulin pumps, and then part of it goes through the physician's visits, your regular doctor's appointments. So the American Heart Association and the American Diabetes Association had partnered a few years ago with this theme, no diabetes by heart. Why? Because diabetes and heart disease kind of go hand on hand. And so whatever I mentioned about diabetes, what you're learning today, how can I prevent diabetes? It's also going to help prevent heart disease or help you manage heart disease better because it's the same thing. So when I'm talking about diabetes, many times I feel like I'm talking about heart disease. That's how they go together. So the pathophysiology, if you don't know what diabetes is or you still don't understand how it happens, is the pancreas is an organ that is close to the stomach that releases a hormone called insulin. And insulin is what we need to keep our glucose control. And glucose is the same as sugar. So if you hear me say glucose or sugar, I'm talking about the same thing, but we need to release that insulin to help balance our sugar. So what happens with diabetes? The body is not responding. It's producing some insulin and the body doesn't respond to it. It doesn't work. So glucose, sugar is going to go up. So the insulin is that key that we need to open the cells. In our body organs, we need to get glucose, sugar into the cells where we can use that for energy. But in order to get sugar in there, we need to open the cell with the key, which is insulin. So if that insulin is missing, where do you think that sugar is going to go? is not going to be able to get in the cell. You're not going to be able to use it for energy. So it's going to go to all the organs. It's just circulated in the bloodstream, head to toe. And the diabetes is a disease of small blood vessels. So all these organs are going to get affected. The eyes, the kidneys, your heart, your toes, because that high blood sugar, it is causing some problems, some damage. So over time, there are going to be some symptoms or something that is going to show, but it can be prevented. We need to get that sugar down. We need to get it into the cells for energy so that we can prevent all this other damage to the organs. So how do we do that? Right? Because this diabetes complications are going to happen if we don't do something. So diabetic retinopathy is when people start going blind because the high blood sugar is damaging the blood vessels, microvascular tiny vessels in the eyes from being there all the time. And then peripheral neuropathy on your causing amputations, high risk for amputations of their toes, their feet. And then we have heart disease, which is 2 times higher risk for a heart attack and a stroke when a person has diabetes than a person that doesn't have diabetes. So there is a 2-time higher risk. So that's what we worry about. And then we have diabetic nephropathy, which is the damage to the kidneys. Then this is the leading cause, diabetes, end-stage kidney disease, which leads to dialysis or transplantation. So we get a lot of patients that get a kidney transplant. And once they have that transplant, we try to help them manage their sugars really well, very strict control so that they can save that transplant, that kidney, because we don't know that they're going to be able to get another one if they lose that one. So we get patients with kidney transplants that get sent to us for diabetes education. And then we guide them on what they need to do to get their sugars under control. So if they have their sugars under control, they can live a happy, normal life like anybody else. They just have to keep an eye on that. So there are, these are long-term, very long-term complications of diabetes that can be prevented if we get that sugar under control. So what are the risks for diabetes? Obesity, family history, gestational diabetes, inactivity, age, medications, ethnicity. So some of this, we can do something about that to lower our risk of getting diabetes. Some of those, we cannot do anything about it. So if we have that risk, then we need to work hard on the other ones that we can work on. And like I have family history, both sides of my family, so I cannot do anything about that. I have very high risk. Ethnicity, I'm Hispanic, I'm Mexican. And age, I'm over 45. And I never had gestational, so I'm okay there. But obesity, lifestyle, medications, I can do something about that to helpfully prevent the risk for me. So what are the risks for heart disease? Diabetes. You have diabetes, very high risk for heart disease. High blood pressure, high cholesterol. We go over this with the patients when they come to see us, the ABCs of diabetes. Smoking is one of the toughest addictions to have, to be able to quit smoking. Obesity, age, gender, and family history. And then diabetes-related factors are chronic kidney disease, chronic inflammation, autoimmune conditions. Now we got to monitor inflammation because it can cause high risk for heart disease, premature menopause, high risk for race, ethnicity, and all that. Nothing I can do about that. So we need to make sure that we get that diabetes under control. So heart disease is very common and very serious. Leading cause of death in both men and women. Diabetes is the seventh cause of death. And it's very difficult to have the right data for that, because when people die from diabetes, it's hard. They don't put that death was due to diabetes. It was death due to something else, which was probably caused by diabetes, but it's how they document the death. And so it's harder to track. So it's the seventh leading cause of death. The longer people have diabetes, the greater the risk for developing heart disease. So where do we start with diabetes once we know we have it? The ABCs, A1C. We need to know what is the A1C currently. If it's high, how can I bring it down, right? You need to start a plan with your doctors, with the whole diabetes team, registered dietitian, diabetes educator, medications. But ABCs, A1C is important to know where you are with the A1C. Blood pressure. Where is your blood pressure? Are you having high blood pressure? Are you taking medications? Do you need medications to bring it down? Cholesterol. Are you taking diabetes, cholesterol medications? So you need all these medications for all these different things in order to help you get everything in control. And so we start with where you are with diabetes. What is your A1C? What is your blood pressure? What is your cholesterol? What are the medications that you're currently taking? And then we start making recommendations to the physician. This patient should start on this medication. Metformin is one of the first medications that we start you with. If you tolerate that, good, take it. If that's enough, that's all you need to take. If it's not enough, not working well, sugar is still elevated, then we need to add another medication. And then we need to add another one. And we need to do whatever it takes to help bring the sugar down to the normal range. So this is the normal parameters for sugar. For people that don't have diabetes, if we are fasting or before a meal and we happen to check our sugar, we have to be less than 100 milligrams per deciliter. And if we check 2 hours after eating, then we need to be less than 140. And this is for people that don't have diabetes or those that have pre-diabetes. And the A1C has to be less than 5.6. That's what you want to know. Where is my A1C? Because the A1C, once it's between 5.7 and 6.4, that's pre-diabetes. And that's when you need to hurry up and do something to bring it back to normal. When people have diabetes, then those parameters are going to change. We want their sugar to be at least, right now it's between 80 and 130. Sorry about that. It's 80 to 130 before meals, less than 180 at 2 hours after the meals, and the A1C less than 7%. So we're happy if people with diabetes bring the A1C down below 7%. That means their diabetes is in good control, and we just watch it. But whenever the A1C goes over 7%, now it's uncontrolled diabetes. Now we need to change the treatment again. We need to do something, talk about the diet, talk about physical activity. What else can they do to help bring that sugar down? So know those parameters and see where you are, and start with the A1C with your lab work. Go back and review lab work from the past years and see where you have been, because that labs sometimes may show normal, but sometimes if you don't catch it, you could go years without knowing that you have diabetes, or that you have prediabetes already for a long time. So, and I always recommend that you go to the lab fasting. There are still a lot of providers that don't believe in fasting, but I always do my labs fasting, even when they tell me you don't need to fast. I always go fasting because I want to see what my glucose is going to be and that result. And that's the first thing I look at, because I'm so worried to get diabetes. So check back, go back on your history and see. Always get a copy of your labs and review them to make sure that you're still okay. So where should you start? You want to meet with a registered dietitian. You want to work on a meal plan. What can I eat? How can I tweak my meals to help bring my sugars down, or bring my cholesterol down, bring my blood pressure down? You can start with the food. You can make a change there, and it helps bring everything down, if you're willing. If you go to this website, diabetesfoodhub.org, that's the American Diabetes Association website. And on this site, they have wonderful recipes that are healthy. These are all done by registered dietitians. They provide you the recipe with the breakdown of the portion, the amount of carbohydrate, calories on each serving. And the recipes are pretty healthy and easy to make. So they give you the ingredients, how to prepare it. They have desserts, they have all kinds of foods. And so go check it out, check that website. They have very good recipes there. And then whatever motivates you to start moving, if you're not moving physically, physical activity is recommended. That will help you bring your sugars down just by doing a quick walk. I said, do whatever it takes to motivate you. Because if you're like me, I'm like, if you see me running, you better run too, because something is chasing me. I don't run, right? So I'm like, oh, you better run behind me. So I don't run, but you want to do something, because when we ask people to start moving, is that physical activity, getting their heart rate up, is going to help lower their sugar. That's the natural way. You don't need to take medications for that. And adding regular physical activity, at least 30 minutes a day, is about 150 minutes a week that is recommended for everyone. And you start slow, or whatever you can do. If you only are able to do 5 minutes, 10 minutes a day, then you start there, but you eventually want to build it up to where you can do 30 minutes a day. If you can do it every day, then it's great. But if you do your 150 minutes a week, then that's wonderful. And you want to make it fun. So I went to training in Chicago, and they have us do these exercises. It's called the Excite program. This is the Henry Ford Health, where the hospital where they do these chair exercises. So this guy is an exercise physiologist who is teaching her how to do chair exercises. And we did it, and I found it very easy for me to do, because I have really bad knees. And so sitting on a chair and just following along this video, it gets your heart rate up. Just make sure it's a chair without arms. And you just follow along. And he even gets a little bit short of breath there, because it's a workout, but you're sitting, right? And you're still able to get the benefit of physical activity, even if you're not able to go for a run or go for a walk. But obviously walking is free. You find a partner that can walk with you and make it fun. If you're doing something you hate, then don't do it. It's not going to last long, because it's not fun. But I'm always looking for things like, what can I do that I can do with my knees? There's another one on YouTube called Walking Down Your Blood Sugars. It's basic aerobics, and those I can do. But when it comes to doing squats, I can't do that. So I don't go too low. I just go to wherever I can that is not painful. And then I do all the other stuff. And it's easy to do. And I get the heart rate up. What are the benefits of physical activity? Lowering your blood pressure, cholesterol, your sugars, right? Depression. Best medicine when you feel down, when you're depressed, you don't feel like doing anything, you're overwhelmed with diabetes. But you lose weight, you can build muscle, it strengthens your heart. So start getting active. So once we start with this, working with someone with diabetes, so that come to see us, then we start talking about, can you monitor your sugar? A lot of people don't want to, because that's why they don't want to come to see us many times, because who wants to be poking the finger all the time? It's painful. So we ask, are you monitoring your sugar? And they're like, no. Can I give you a meter to start? No. Right? So these days is the best time to have diabetes now. I always tell people, oh, this is the best time to have diabetes, because now we have the continuous glucose monitors that people are using. It's a little tiny device that you insert on the back of the arm, and then it sends your sugar directly to your phone every minute or every 5 minutes. And you change it yourself every 14 days or every 10 days. But these devices are very, very popular. So we start our patients with a sample, we put it on, we have them come back in a couple of weeks, and then we start the process so that they are able to get these devices at home, covered by Medicare or the insurance. And when they come back, we teach them, we train them on how to put it on themselves. And then from there on, they start changing it themselves every 10 days or every 14 days. So the Freestyle Libre and the Dexcom are the two that we use. And sometimes it's by the patient's preference. Sometimes it's by what the insurance covers. but we tried to get them on those right away. So it's going to give us a lot of information that we need to see where that person is with their sugars, what's going on. To wear it for a couple of weeks, come back, we download the device, and then we look at the reports and we go over what is going on. We also have these devices that if someone is injecting insulin when they come and see us, sometimes they are going on insulin right away when they get diagnosed with diabetes. And then we have now devices that they can use to get insulin continuously without having to inject the insulin all the time. Because if they are on two insulins, the long acting and fast acting, they end up injecting 4 times a day at least. And so these devices are making it a little easier. So they put it on, they change it every 24 hours, but it's continuously delivering rapid insulin. And for mealtime, instead of injecting the fast-acting insulin, they just click the button twice, or every time they click it, they get 2 units of insulin. So if they need 4 units, they just click it twice and that's it. But they're not injecting. So that motivates people to really wanting to inject their insulin, right? Because they're not injecting all the time. So these are great. These are all the continuous glucose monitors that we have currently available. The ones we use are mostly the Freestyle Libre and the Dexcom G6. I am wearing the Libre 3. That one just came out a few weeks ago. I want to show you. It's the size of a penny. See, I don't know, hopefully you can see it. Do you see it? Where is it? Right there. So it's very small, the size of a penny. And what it does, you don't have to scan that one anymore. You just go to your phone and you open the app, and that sensor is sending my glucose to my app, to my phone, every 60 seconds. So if I want to know what my sugar is, I just need to open the app. And I wear that for 14 days. And I don't have diabetes. I'm just testing it because it just came out. And I put all the devices so I can tell you how they work, what you need to watch for. But these are wonderful. The other one, the Libre 2, this one, if someone has it, you do have to still scan it with the phone or with the reader to be able to see your sugar. You just swipe it close to the sensor and then you'll see it. This one is the new one that now you don't have to scan it. It just automatically goes to the app. So then we get, like I said, we also have insulin pumps now that communicate directly to the sensor. It tells the pump what your sugars are and how to adjust the insulin automatically. So people get controlled, their sugars controlled very, very easy now, a lot better, faster. This is Dr. Edelman. He has type 1 diabetes and he's wearing the Omnipod insulin pump that he uses the phone to dose his insulin. The device is continuously giving him a dose 24 hours, but for the meals, he will have to open up the phone and go bolus the dose for the meals. So he's showing off his biceps. He always does that. So these are the reports that we get, and you do have access to your reports. So what are we looking at? We want to make sure that you are in the range and the target between 70 and 180 if you have diabetes. I don't have diabetes, so I changed my range to 70 to 140, right? So I get an alert or alarm if I go low or if I go high. And if it's giving me a high, they're saying that I'm high or that I'm low, I need to go do a finger stick to confirm it, just to make sure, because I feel fine. I don't have any symptoms. I don't have diabetes, so I need to go and check. And so we're looking at this to how long of the time you are in the range, how long of the time are you high, how long of the time are you very high, and how long of the time are you very low? Because we need to be adjusting your medications. We don't want you high, we don't want you low. We want you in the range, at least 70% of the time in this range here in the green. And then on your phone and on the device, you can actually go and look at your reports so that you can see what we are looking at, how you are doing with the new changes on your medications. So with the exercise now that you're walking or running, how much is bringing your sugars down. So this is wonderful because we link our patients now to our account. We pair you up to our system So that if you call, say, Marielena, I'm having trouble, my sugar is too low, my sugar is too high, I can log in and look at your report and then call you back and say, oh, let's lower your insulin. Let's talk about this, what's going on, and then help you that way. You don't have to come in to my office. So it works wonderful. This is the Dexcom report. Look how nice the person is on in the range, 70 to 130. This is Dr. Ponder. He's the author of Sugar Surfing, and he's an endocrinologist. He has type 1 diabetes, and he shares all his reports because we cannot use patient information to show you a report, but we can block it. And so I realized that when I was using this, I'm like, I'm going to use Dr. Ponder. He doesn't mind. He puts it all online. And he's 95% in range, averaging his sugars at 111. He's doing great. It also estimates what your A1C is going to be. So people know ahead of time before they know they're coming to see us. They start worrying about it and they start walking faster and longer because they're like, oh, they're going to see my A1C. And you can see it there that your sugar is going higher, it's going lower. And so, but it's just for us, it's just to evaluate this and help you get your sugars under control. That's it. Not to judge you, criticize. Why did you eat that day? Why did you go so high? It's none of my business. It's to see what you're doing, what lifestyle changes are you making, and is the treatment working? This one I can't read up here because the bar is there, but it's diabetes recommended vaccinations too. People with diabetes are more susceptible to getting something. Their immune system is a little weaker, so they need to have these vaccines. And then we just added influenza is the one that we push everybody, get your flu shot. Hepatitis B, and we just added COVID for everyone to get their vaccines. I have all of them. And then this slide here, I'm going to go really fast on this next few slides because let me see what the time is. But blood pressure medications, I just wanted you to show you how many medications we have for blood pressure. Because if you have heart disease, you must be taking something, right? But these handouts give you all the blood pressure medications, the two names. You need to know the name of your medications, not the color. When I ask someone, what is your, what medication do you take? It's the blue one. I'm like, Viagra? What is it? They're like, no. So don't go by color. You need to know the name of your medications, the dose and what they are, what they do, how they work, how you should be taking them. So we evaluate all your blood pressure medications. This one has 3 pages. And you can get these handouts for free online at the diabetesed.net website. I like using this for my patients. I highlight why they're taking and how much and how should they be taking them to make sure that they consistently take them. And we have the cholesterol medications for the statins and the lower triglycerides. All the insulins, we do a lot of education on what insulins is the patient taking, how long are they good for once they open them. I have patients that believe that when they open the pen, a year later, it's still good. 28 days once you open it. And so when they come back with very high blood sugars, we evaluate their medications. Hey, maybe it's expired for sure. So we want you to have all this information. So it's available to you. We have all the long-acting insulins, fast-acting insulins, combinations of insulins with GLP-1 medications and long-acting insulins. And these are really good medications to have for diabetes. A lot of people don't want to go on insulin, but sometimes they need to be on insulin right away. Other times we allow them to try all these other medications first to see if that's enough, all they need. And then before we add the fast-acting insulin, these are all fast-acting. And then I wanted to spend a couple minutes on one of the medications that is new. So I want to tell you why. But we have all these long-actings. We have inhaled insulin. For those that have needle phobia, that will be a good medication insulin to have. It works really fast. It gets out of the system fast, and everybody's happy. So these are medications that I want to spend a couple of minutes on. This one is, they're called the GLP-1s. It's the glucagon-like peptide 1. And these medications work really great. So people without diabetes, when we eat, our food stays longer in the stomach. We're not hungry, we're full, and we can wait and eat until the next meal happily. But people with diabetes, when they eat, within 2 minutes, they lose an enzyme. They lose this hormone amylin. This appears within 2 minutes when they start eating. So then they're never going to get full. They're always going to be hungry. And they're always going to be eating. Right. And so these medications actually help because once they start injecting them, these ones are injected. Some of them are Byetta and Victoza. Byetta is injected twice a day, but we don't use that anymore. That's the first medication that came out many, many years ago. Victoza is injected once a day, but Trulicity, Ozempic, we have now Mounjaro. All of these are injected once a week. And so the patient takes the injection and they start getting less hungry. Now they feel full and they're not eating all the time. So guess what happens to their blood sugars? Gets control and they lose some weight. So these medications are wonderful because people start losing all kinds of weight. But this new one, Mounjaro, it just came out. Is the only medication in that category. Is called the GIP, which is the glucose-dependent insulinotropic polypeptide, GIP, and glucagon-like peptide, GLP-1. It's this only first medication of this type. So this one just came out not long ago, and everyone wants it. This is a diabetes medication. It's approved for type 2 diabetes. And so this one showed, and the studies they did, it showed had an impressive reduction of the A1C and weight loss. The trials that they have, the Lilly is the company that makes this insulin currently, is in clinical trials for weight loss to get this medication approved for people that don't have diabetes, that are overweight or obese, so they can help, they can also take it for weight loss. And so I was reading about this when I was getting ready for this presentation, and everyone is trying to get these medications for weight loss, and they are getting them. And that's leaving people with diabetes without medications. So they're running out because everyone started using them, even the ones that don't have diabetes, for weight loss. And so there has been a back order. So people end up using another one of the same family, but a different one, because the one they take, they cannot find it. So the companies are increasing production to try to keep up with the demand because these medications are wonderful for weight loss. But we cannot promote these medications for weight loss. These are diabetes medications. It just happens to have weight loss. And this is how much people weight. They start a dose of 2.5 milligrams for 1 month. Then they'll increase to 5 milligrams for another month, 7.5 another month, 10, 12.5. The highest dose is 15 milligrams. So they will increase as long as they're losing weight. Maybe they stay there longer, but if not, then we keep advancing the dose. But so I was reading about that, and I'm like, wow, everybody wants that. But as soon as it gets approved for people without diabetes, we're going to put everyone on it. I can take it too, right? And then we have the oral medications too that are wonderful for cardiovascular disease. Actually, Ozempic, one of the weekly injectables. Those medications are now being used a lot by cardiologists because of the cardiovascular benefit. Chronic kidney disease, they help to prevent the advancement of that disease for kidneys, heart failure. So we're putting a lot more people on those too, even if they don't have diabetes. Some people are getting those medications because of the studies that they did, the cardiovascular benefit. Jardiance is one of those that is being used a lot by cardiologists for patients with heart disease. And that's a diabetes medication. That one is an oral medication that they take once a day. It makes them pee out the sugar, extra sugar. People lower their blood pressure, they lose weight, they lower their sugars. And we just had to do a good education about making sure they clean really well when they pee so they don't have any infections, men and women, and monitor that they don't get dehydrated. But that's a good medication that we see cardiologists using all the time for heart disease patients. Jardiance, here it is. So it was recommended by the American Diabetes Association because of the non-heart disease benefit once the patient is taking metformin. For type 2 diabetes, let's add this one too if they have heart disease. Here it is, heart failure or cardiovascular or chronic kidney disease. We could use the SGLT2 Jardiance, or we could use GLP-1 for people that have the other atherosclerotic cardiovascular disease. So GLP-1s, SGLT2s, those are diabetes medications used for people with heart disease or chronic kidney. There are a couple medications that are approved for weight loss, and this is for people that don't have diabetes. This is everybody, if they can get it. Wegovy is one of them, and it's people that need to have a BMI of at least over 27. They need to be an overweight or obesity to be able to get this. They need a prescription. These medications are very expensive. You see here is $1,400 a month, right? And some people are willing to pay if they can, but if insurance covers them, maybe they don't have to pay as much. The highest dose is 2.4 milligrams, and it's injected also weekly. And then we have Saxenda, also approved for people without diabetes for weight loss. And kind of the same thing. This one is injected once a day. And it does help them feel, and I want you to look at the side effects for all of them. The GLP-1s, they all may cause nausea the first week, the first few weeks, getting your body ready. That's why we start at a low dose to get your body kind of prepared for it. So you may feel nauseated, and some people may vomit. And then once they start accepting it, if the body's going to tolerate that, then they can stay on it, and then we start increasing the dose. But if people have in the family history of thyroid tumors, things like that, we don't put them on these medications. Someone has risk history of pancreatitis, we want to be very careful when they take these medications. So I always tell people, read the insert when you get a new medication, just to see what are the possible side effects, so that you're aware that that's a new side effect, maybe you don't tolerate that medication as well. We need to take you off of it. You don't want to keep taking something that it's going to harm you. It's not going to be good for you. So also GLP-1s and SGLT2 inhibitors should be taken as prescribed by your doctor, along with practicing heart healthy. There is no magic medication that we're just going to take and lose the weight and not do anything. It's always come in the small print with healthy eating and physical activity. We need to do our part too. So you can lower your risk for type 2 diabetes by 58% if you lose 7% of your body weight. So for example, someone weighs 200 pounds, they need to lose about 15 pounds. If they want to lose 5%, 200 pounds, 10 pounds. Makes a big difference to get their sugars down. And walking, obviously, 30 minutes a day, 150 minutes. And this seems like, oh, people get overwhelmed when they see pictures like this, because they're like, I have to carry all that with me. People with diabetes do. They have to carry extra something to carry all their supplies. If they need to go somewhere and inject insulin, or their sugar goes low, they need to have something that can bring their sugar up quickly. The medications they need to bring with them, the meter, test strips, lancets. This is something that is kind of, the ones wearing those sensors, they don't have to carry any of that stuff. We can see, what is my sugar doing? So I can prevent it from dropping or going too high. So do what you can. Well, one of the first things I recommend is meet with a registered dietitian. Start working on medical nutrition therapy. Come up with a meal plan. Start adding physical activity, controlling, monitoring your blood pressure, cholesterol, glucose. What are those three doing? And start healthy lifestyle changes. Don't get on a crazy diet that is just not going to last because it's too strict, too restrictive, right? That you want to be able to maintain something for long term, those small changes at a time, healthy changes. And then the last one here is no diabetes by heart. Again, the thing by the American Diabetes Association and Heart Association, that diabetes and heart disease go hand in hand. So we're working on reducing diabetes risk. At the same time, we're working on reducing cardiovascular risk, right? And so high blood glucose levels, look at what they do. They stick to the walls of the vessels and they become very sticky. And that is circulating in the blood. But you see the blood vessel there, how clean, nice it is? And then it starts building up a plaque from high blood sugars, lots of insulin circulating there, high blood pressure. The walls of the arteries start getting hard, and triglycerides, everything is there. I actually brought that vessel that I like to show my patients when I'm talking about heart disease or high blood pressure, or why they need to make sure they take their medicines, and how the vessel looks clean, and then how it looks when it's building that plaque. There is very little room for blood to go through. And so once it gets blocked, it can cause a heart attack, blood clot, and then they have a heart attack. They can have a stroke if there is not much blood flow. So we want to keep our blood vessels clean, get the blood going, exercising, getting all those down, and quit smoking is the big one. And with that, I like to invite you now that I motivated you to prevent heart disease and diabetes, to join us for the Heart Walk. It's Saturday, November 19th at the Civic Park. And it's going to be fun. It's a beautiful day usually. You're welcome to join our team. Eisenhower has 4 teams. Ours is Diabetes Education Services. You're welcome to sign up on our team and come and join us. It's in a couple of weeks. So get involved, try all the donations, all the money that is raised for the American Heart Association goes to the research so that you have better treatments. And then we can find the cure for a lot of different cardiovascular conditions. But join us. And then with that, I am going to leave it open for questions now. Thank you.
All
Yes.
right.